All right, let's get right into it. When a heart stops inside a hospital, it can look like pure chaos. But believe it or not, there's a highly organized, life-saving script that everyone follows. It's called the Advanced Cardiovascular Life Support Protocol, or ACLS for short. This is way more than just chest compressions. It's the specialized playbook that healthcare pros use to turn an absolute crisis into a clear step-by-step plan.
So put yourself in this scene. You're on the floor and someone just collapses. The clock starts ticking now. Every single second matters. This is what we call a code blue, and the ACLS protocol is your roadmap. So what's the very first thing you do?
Okay, so the first phase is all about assessing the situation at lightning speed and getting help on the way. Before you can even think about advanced treatments, you've got to nail these first few steps with absolute precision.
Your initial response is a super fast 4-step check. First up, tap them and shout. See if they're responsive at all. Are they with us? Step 2, check for breathing. And here's a really key point. You're looking for normal breathing. If a patient is making these weird gasping sounds, we call that agonal breathing. That is not normal breathing. If you get no response, you move to step 3 immediately. Hit that code blue button, call for help, get the crash cart, get the defibrillator. And finally, step 4, check for a pulse in the carotid artery in the neck, but, and this is critical, for no more than 10 seconds. Any longer than that is time you just don't have.
If you don't feel a pulse within those 10 seconds, that's it. The decision is made. There's no waiting, no second guessing. You start high-quality CPR. Right then, right there, immediately.
Now we get to the absolute foundation of everything, the engine that keeps the patient's brain and organs alive while the team does its work. Seriously, everything else we do depends on the quality of these chest compressions. This isn't just pushing on a chest. There's a real science to it.
Let's just burn this number into our brains, 100 to 120. That's how many compressions you need to do per minute. It's the beat of survival. You know, people always mention the song Staying Alive. Well, it's not just a joke. The tempo is pretty much perfect for saving a life.
So it's not just about speed, right? It's how you do them. You have to push hard, at least 5 centimeters. That's about 2 inches deep. That's what it takes to physically squeeze the heart and force blood out to the brain. Then, and this is so important, you have to let the chest come all the way back up. That full recoil creates a little vacuum that pulls new blood back into the heart for the next push. We follow a strict ratio, 30 compressions, then 2 breaths. And maybe most importantly, you have to minimize interruptions. Every second your hands are off the chest, blood flow to the brain just stops. So we keep those pauses to less than 10 seconds, period.
All right, help has arrived, a defibrillator is hooked up. This is the first huge fork in the road in the ACLS algorithm. The patient's entire treatment plan for the next 2 minutes is going to be decided by a single question about the heart's electrical rhythm.
The pads are on, the machine is analyzing, and everyone is waiting for the answer to this one question. Is this a rhythm that electricity can fix, or is it something else? This one answer changes everything.
And this lays it out perfectly. On the left, you've got your shockable rhythms. There's ventricular fibrillation, or VF, which is when the heart is just quivering chaotically, and there's pulseless ventricular tachycardia, or VT, where the heart is beating so fast it can't actually pump any blood. For those two, the action is clear, shock. On the right, you've got the non-shockable rhythms. There's asystole, which is the classic flatline, no electrical activity at all, and then there's pulseless electrical activity, or PEA. This one's tricky. The monitor shows a rhythm, but the heart muscle isn't actually squeezing. For these, a shock would do nothing. So the action is no shock, just keep doing great CPR and give medications.
And here is a golden rule. This applies every single time, no exceptions. Doesn't matter if you shock the patient or not. The second that decision is made, hands go right back on the chest. You immediately start CPR again for a full 2 minutes. You never, ever delay compressions.
Now, when a shock is needed, the process is a simple 1, 2, 3, designed to be foolproof under pressure. 1, you select the energy. For modern biphasic defibrillators, that's usually 200 joules. 2, you hit charge and loudly announce clear to make sure no one is touching the patient. 3, you press the shock button. And here's a pro tip. In a cardiac arrest, you never use the sync button. That's for a different procedure on patients who still have a pulse.
So while the compressions and shocks are happening, another team member has a totally different job, getting access to the bloodstream. That means getting an IV in, or if that's not possible, a line directly into the bone marrow, called an IO. Because at the same time we're doing everything else, we're also fighting this battle with medicine.
The #1 drug in any cardiac arrest is adrenaline, also called epinephrine. We give 1 milligram every 3 to 5 minutes, no matter what the rhythm is. This stuff is powerful.
it tightens up the blood vessels, which helps push blood back towards the heart. Now, if you have a shockable rhythm that's really stubborn and it's still there after the third shock, that's when we bring out an antiarrhythmic drug called amiodarone. We hope it'll help stabilize that chaotic electricity.
Okay, let's talk about breathing for a second. At some point, the team will usually place an advanced airway, like a breathing tube that goes directly into the windpipe. Once that's in, the whole rhythm of CPR changes. We don't have to do the 32 ratio anymore. Instead, one person does continuous, uninterrupted chest compressions while another person gives one breath every 6 seconds. It's way more efficient and keeps that blood flowing without any pauses.
So far, we've really been focused on the what of ACLS. The steps, the drugs, the shocks. But the most important part of the whole process is often asking why. Why did this person's heart stop in the first place? Because if you don't find and fix the underlying cause, they're not going to stay alive for long, even if you get their pulse back.
This is the big mindset shift. You're not just running a protocol on a squiggly line on a monitor. You're treating a whole person. You have to become a detective, right in the middle of all the action, trying to figure out what went wrong.
And to help with that detective work, we have a mental checklist. It starts with the 5 H's. Could it be hypovolemia? Did they lose a lot of blood or fluid? Is it hypoxia? Are they starved of oxygen? Hydrogen ion? Is their blood way too acidic? We also check for hypo or hyperkalemia. Are their potassium levels dangerously high or low? And finally, hypothermia. Are they critically cold? The great thing is every one of these is potentially fixable.
And the other half of that checklist is the 5 T's. Could it be a tension pneumothorax, a collapsed lung that's crushing the heart? Or tamponade, fluid building up in the sac around the heart and squeezing it so it can't beat? Maybe it's toxins like an overdose. And finally, thrombosis, that means a clot, a massive one in the lungs called a pulmonary embolism, or one in the heart's own arteries, which is a heart attack. Finding and fixing one of these H's or T's can be the key that unlocks survival.
So, with all this effort, what's the goal? What are we fighting for? It all comes down to a single acronym, ROSC. It stands for Return of Spontaneous Circulation. It's that incredible, breathtaking moment when you pause compressions for a pulse check. You put your fingers on that carotid artery and you feel it, a pulse. Their heart is beating on its own again. That is the win. So, as you can see, the ACLS algorithm is just a masterpiece of organized chaos. It takes you from the moment of collapse all the way to ROSC. But getting that pulse back, well, that's not the finish line. It's really just the end of the beginning. The next battle, the one to save the patient's brain and the rest of their body, has only just begun. And what happens in those next critical hours? Well, that's a whole other story.